Everyone, thanks for joining me today in session 266. I am joined by Dr. Chris McGinnis, and we sit down and talk about his work in primary care behavioral pediatrics. If you're not sure what that is, don't worry. We go over that right away and learn that this area of work sits in an important and underserved niche, this niche between the general behavioral advice dispensed by pediatricians and intensive treatment for serious mental health challenges. In a way, this conversation expands on something that Pat Friman brought up in our most recent interview, the idea that BCBAs are uniquely suited to provide families with this type of care. In order to provide direction to those who are interested in doing just this, Chris recently published his latest book, Introduction to Primary Care Behavioral Pediatrics, a guide for behavior analysts. I'll have a link to that in the show notes for this episode. So in general, our conversation covered the following. We talk about Chris's background in behavioral pediatrics, including his work at BoysTown, and I guess as an aside, his meeting of Pat Friman for the first time. We talked about the motivation for writing this book. We talk about the reification of psychological terms and hint at a lot of, kind of Skinner 45 stuff. We talked about we did a little myth busting, including the chemical imbalance hypothesis. We talk about the range of behavior challenges he sees in his practice, his thoughts on caregiver adherence, and we talk about the business of doing this as well. In particular, we talk about the pros and cons of different reimbursement practices, including the concierge model he has currently adopted. And I think you're really going to enjoy the last few segments of this podcast. We talk about Chris. He's embarked on this kind of self-study of trauma-informed care, and he shares his thoughts on that. There's a really interesting bit that we get into about permissive versus authoritative parenting and how those might be related to adolescent mental health. And long story short, parenting, he likens it to a marshmallow test, if you will. So you're going to want to check that out. And that's at the very end of the show. Well, it's right before he gives some great advice for the newly minted BCBA. That's how the show ends. So longer than normal episode. And I think if you stick through the whole thing, you will be rewarded because, again, we really get into some interesting topics throughout the entire thing, but particularly towards the end. This podcast is brought to you by our newest sponsor, the New England Center for Children. I am beyond thrilled to partner with one of the oldest and well-respected ABA institutions to help them find staff to continue their mission of supporting individuals with autism. Right now, they're recruiting for staff in Massachusetts, New Hampshire, and Vermont. So to learn more about their offerings, go to necc.org/jobs. We're also brought to you by CEUs from, you guessed it, Behavioral Observations. That's right. You can get your CEUs while driving, walking your dog, doing the dishes, or whatever else you have going on, all while learning from your favorite podcast guests. Just go to behavioralobservations.com/get-CEUs to learn more. We're also brought to you by HRIC Recruiting. So if you're about to finish school, if you're about to move, if you have any questions about the jobs in behavior analysis, go to hricolorado.com and schedule a confidential chat with Barb right away. And last but not least, we're brought to you by the Behavioral Toolbox. That's the new education and training site that my colleagues Anika Costa and Dr. Polly Gavoni and I have been working on for over 2 years. Right now, we have 2 courses available, and these are perfect for school-based BCBAs. One of them is called Ready, Set, Consult. And the latest one is When Not to FBA, 5 Quick Strategies for Improving Behavior in Classrooms. And we've gotten a lot of great feedback on both. So if you're interested in either of those or both of them, go to thebehavioraltoolbox.com to learn more. That's it for opening remarks. I really hope you enjoy this conversation as much as I did. So without any further delay, here's Dr. Chris McGinnis.
Welcome to the Behavioral Observations Podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
All right, Dr. Chris McGinnis, thanks for joining me today on Behavioral Observations. We've been planning this for quite some time and finally managed to do it. So again,
Absolutely.
Thanks for joining me.
Well, it's an honor. Thanks for having me, man.
So we're going to get into all sorts of things about behavioral pediatrics and what that is and how you practice in that area. Let's start off like we always do, though. What was your first encounter with behavior analysis, and what made you want to pursue it as a career?
Yeah, that's a good question. So, I was thinking about this, and in undergraduate, I think like a lot of us, anyone who went into, I'm a psychologist, I should start out. I'm a behavior analyst and a psychologist, and I originally went to school for psychology. In undergraduate, it's interesting. I learned about behavior analysis as just another personality theory. That's how it was discussed. Skinner was listed right along with, everyone else, like from humanistic psychology and, and Rogers and everybody else. And I decided to go on to graduate school, and I decided to go into school psychology. And I didn't quite know exactly what I was getting into, but I really lucked out because I went to a behavioral program, and that was the Southern Miss School Psychology Program. That's where I learned about behavior analysis. I didn't, I heard about it before, but I didn't really learn about it. And I learned not only about the philosophy of it, but also how to apply it. And the more I learned, the more I began to see behavior analysis as an engineering science. And that's kind of how I look at it now. It's a science of how to engineer outcomes. And that's useful because I don't know if there's anything else like that in psychology.
When you were an undergraduate, did you just had a general interest in psychology, and what made you want to pursue that? And well, as a fellow psych major, I'm just curious.
Yeah, it was a funny story. I originally went into business, which I don't know why I chose that because it wasn't interesting to me. I just had to pick something, I guess. Wasn't really interested in it. Bounced around communication, music. I tried, and in the end, I looked at my transcript to see what I had the most classes in, because I had to pick a major and I had to get out of college at some point. And I saw that psychology was what I had the most of. It's interesting to look at it that way. And so I was talking to a counselor of mine, just making sure that I was on track to graduate on time and things. And so we ended up from there deciding to only do psychology classes from that point. And I got to tell you, I was really turned on more by psychology at that point because that's all I was studying. I was really focused on it. Got to know my professors, and that I think that's what made me really focus and decide to go on to graduate school as well.
Speaking for myself, I was always a psych major. I always wanted to be a psych major, but I think my study skills and I guess the seriousness with which I approached the material increased quite a bit towards those last couple of years when you're just taking your core content classes, and it gets more fun, and I can identify with that again, that focus. So good stuff. So take us through to so you had some training experiences that were kind of unique. So tell us where you went from there.
Yeah. So I didn't know this at the time, but looking back, I learned when I got my degree that it was an accelerated doctorate. So I got all my graduate classes in within 3 years. And then I did an internship, and the internship is really what I needed. I got a lot from Southern, but when it comes to doing behavioral pediatrics, I didn't know anything about that. I knew about, solving some problems, some clinical problems that, you would find in the schools, for example. But I didn't learn I never heard the term behavioral pediatrics until I got to my internship. And that was the Nebraska Consortium, and that was BoysTown. So that's when I met Pat Friman.
I see. And so at that time, when you got to that internship, did you know who Pat was, or did you have any clue as to his stature in the field, or what he brought to the table?
I hate to admit it, but I didn't.
Okay.
I didn't.
So what were your impressions when you first met him? I'm just curious what that was like, not having any background or anything like that.
Well, I know Pat remembers this because we'd talked about this since, but the way let's see, how do I say this sufficiently? When I was going to the Nebraska Internship Consortium for interview day, you basically, sit in, a bunch of chairs, all of us, and then there are these sites like BoysTown and others that are at tables all along the wall, and they call you and they interview you. And that's how it was over 25 years ago. I don't know how they do it now, but Pat was sitting at one of the tables, and they called me over, and it was anxiety producing and awkward, to be in that situation. But I got to tell you, he put me at ease, and we ended up having a fantastic conversation. And it was, after that, I don't know, it must have been about 20, 30 minutes. That's where I wanted to go.
I see. And so what did you end up doing for your internship? What was the day-to-day like?
Yeah, that's interesting. So what makes that interesting is that BoysTown now has dedicated clinic building on site there in Omaha. But when I was there, I think I was only the second intern class that Pat had there. I think, if I'm not incorrect, I think that's second or third, probably the second. And there was no clinic. We did a lot of discussion about philosophy, principles of behavior analysis, and how to apply them. And we had an opportunity also to consult on campus there with the classrooms in the schools that are at BoysTown, but also the children that are at BoysTown. It was nice to be able to meet with them occasionally and to offer some services, and also help the family teachers that the children live with. It was really great. It was the first time. No, it wasn't the first time, because I did practicum at Southern in a clinic situation there. But it was a great opportunity to learn an awful lot about how BoysTown as a community, but also as a agency, how it works, and how to negotiate the politics as you help out with various components of it, like the schools, for example.
What sort of challenges were you helping people with?
Yeah, that's a good question. I was thinking about this, just kind of thinking about, getting my thoughts together for the podcast. And I was thinking about your interview with Camille, about the buffers, which is really, really good stuff.
That was a fun one. Yeah, for sure.
Yeah, exactly. Yeah, it was great. And I have a lot of respect for Camille. And looking back, a lot of it was just making sure that those fundamentals were in place as far as helping out. That was the question, is kind of what did that look like, right? Just making sure that we were helping with the fundamentals, but because the family teachers are very well trained, but they're not psychologists, right? So they're not behavior analysts. They're behavior analytically trained, maybe, but that's why we were there, I suppose, one reason. And so we were helping them out a little bit here and there, and it was mutually beneficial, because I was learning as I was teaching, and that's kind of what it was all about, was just problem solving and applying things that we were learning along the way.
Got it. And so you're now back in South Florida, or now you're in South Florida. And so what is your day job today?
Okay, so yeah,
not that you have a side gig, but I guess, what is your job? I shouldn't.
Yeah, exactly. Yeah, my job.
So Chris, I'm used to qualifying things. So this is my day job. This is my real job, but this is everything else. So, but
yeah, no. My day job, let's put it that way, is that I have a private practice in Jupiter, and it's a small, manageable space, and I consider it a concierge practice. And what I mean by that is it is really, really tailored to the individual family, in a sense that, they can email me or call me at any time, and I'll get back to them as soon as I can. Just really good customer service. Very rare in outpatient mental health, where people feel that taken care of. I think that's something that, I'm really trying to get behavior analysts to see that they can do. But yeah, that's what I do. So I see somewhere between 15 and 25, sometimes 27 or 28 families a week. Full-time weeks, that's how much I put in. So I get in probably around, 8 o'clock in the morning, and I work till probably 6, sometimes 7, 4 to 5 days a week.
Hey everyone, are you looking for a meaningful career in autism education and behavior analysis? Then look no further than the New England Center for Children. The New England Center for Children is the country's leading autism school and research center. And for 50 years, they've helped transform the lives of children with autism. And they're currently hiring teachers and BCBAs in Massachusetts, New Hampshire, and Vermont. NEC offers the industry's most competitive pay, professional development, and benefits package, including free graduate school. That's right, free graduate school. They also provide ongoing training for their staff, from annual refreshers to continuing education units for their professional certifications and licenses. Another great thing about NEC is that learning extends beyond their classroom walls. That's because the New England Center operates 14 residential homes and consults with more than 60 public school districts. NEC also operates a school in Abu Dhabi and clinics throughout the Middle East, and as such, teachers and staff have opportunities to work abroad. If this all sounds good to you, and you'd like to join the more than 500 teachers and BCBAs in making a difference in the lives of children with autism, go to necc.org/jobs to learn more. That's nec.org/jobs. I want to get into what a concierge practice is and the types of things that you've suggested other behavior analysts consider. But I also want to get people on the same, foundational level with regard to terminology and so forth. So this term behavioral pediatrics has come up a couple of times. And you've thought so much about this, you've even written a book about it, Introduction to Primary Care Behavioral Pediatrics. I'll have the link to that in the show notes for people who want to check that out. So obviously it's something, again, you've put a lot of thought into. Tell us, for someone who's not familiar with this area, what do you mean by, primary behavioral pediatrics? What does that look like? What is it? How does that distinguish from other aspects of behavior analysis, et cetera?
Yeah. So first off, I should say that primary care means preventative, right? And a lot of psychological and mental health services out here, when you really get down to it, is more secondary care, meaning that there's an assumption, I think, by a lot of practitioners that once a child or family walks through the door, they're going to be diagnosable with something. That's certainly true if they're going through insurance, which means that you have to tell the insurance company what you're working on, right? So there's something diagnosable. In primary care, you're trying to solve solvable problems as early as possible so they don't turn into something worse, needing more services, more intensive services. Primary care is preventative. So, and then behavioral pediatrics, I kind of see this as filling an unfilled niche between primary care pediatrics and referrals to mental health. You see, that niche is wide open, and an awful lot of psychologists, psychiatrists, just mental health folks in general, pediatricians who are referring kids to mental health know that there are some things that are so mild from their point of view that they won't refer out, for example. But if they do refer out to mental health, I think there's an assumption that it's worse than it is. And so there's over pathologizing medication use that doesn't need to be done. There's such, like I say, I think of it as a niche, but there's a lot of work to be done by somebody between primary care pediatrics and traditional mental health. That gap is wide open, and it's a wide gap.
So this exists in the space between, say, I think, as you pointed out in the talk that you gave at ABAI, which I was fortunate enough to be in the audience for.
Thanks for attending that, by the way.
Yeah, it was good. It was good. Certainly pediatricians are oftentimes the first line of defense when parents encounter challenging behavior from their kids. And, very often pediatricians will, dispense advice, and sometimes that's helpful. And then, so if I'm understanding you correctly, there's like the gap between the thing that the pediatrician can kind of dispense with in the office, given a couple of quick recommendations, whether it's about sleep or this or that, and then individuals with more considerable mental health needs,
right, that
might need, perhaps an intensive workup of some sort, followed, and other sorts of interventions. And so you're between those two poles, essentially. Do I have that correct?
Absolutely. A great example of that is that I don't do any work with eating disorders. I can help with picky eating and things like that. But when it comes to eating disorders, anorexia, bulimia, those are things that when pediatricians discover that, they know exactly what to do in terms of where to send those children to make sure they get what they need, or teens as well, to get what they need. That's not primary care. That's more secondary, you see. So that would skip right over me. And that's fine, because that's not what I do. Another thought too is that I hardly ever go more than about 8 or 9 sessions with a family. And if I do, they might circle back around in 6 months to a year or two because they've got a new situation. They've got a new concern they need help with. And, I bill myself as the primary care person for families when I meet them for things other than medical. I want them to come back to me just like you come back to your pediatrician.
Got it.
Yeah.
I want to come back to that in a little bit, but we mentioned the book, and whenever someone takes the time to do something like write a book, or you mentioned, Camille, a few minutes ago, that huge, just massive scholarly undertaking of that Buffers paper. I'm always curious, what motivates someone to expend all that energy on, and so I want to get into what the book is, certainly, but I want to get the why question first. Why did you write the book? What was the hole in the marketplace that you thought this book needed to fill?
Gotcha. Well, here's the thing with behavioral pediatrics. It's been around for a long time. It's been around for over 40 years in terms of research and development, you could say. And this starts with Edward Christopherson at Mercy Hospital and in Kansas City. You've also got Mike Cataldo, who has forever run the Kennedy Krieger Institute, the behavioral wing of it. But there hasn't been really a whole lot out there in terms of authoritative literature to help behavior analysts know that this is something they could do for a career. It's been around forever in terms of know-how, right? Procedure, but not in terms of career. And so, I'm at a point in my career now where, I want more people around me that do what I do. I don't have a whole lot in common with psychologists. I have friends who are psychologists and we get along and go out for drinks, but we don't have a lot I don't go to psychology conferences. I go to behavior analysis conferences. As John Bailey says, that's where the reinforcement is for me, So I wrote the book primarily because I wanted to take behavioral pediatrics from technical know-how and provide a path for behavior analysts who are new to the field, maybe those who are coming in to the field, or maybe those who have been practicing for a while and they'd like to do maybe something else, maybe respecialize using behavior analysis, but in another way, treating other populations. And so the book didn't exist, and so I wrote it. That's why I did it. And I, just like I said at the ABBA talk, I didn't write it for me. I really wrote it for everybody out there, because I'm trying to get more. Here's another way to say this: if you look at the certificate data on the BACB website, it says that there's about 1% of the world's behavior analysts that are doing behavioral pediatrics, less than that. And then you look and see how many are doing autism treatment, which is wonderful and it's needed. But that's only, not only, that's 71, 72% of all behavior analysts, or at least all certificates. And, if I have anything to do with this, I would love 25, 30 years from now, hopefully even sooner, to see that ratio reversed, where we still have enough people, and we still don't have enough people, but we have sufficient behavior analysts doing autism work. But there's the rest of the bell curve, something Pat's been talking about a lot through his career. And behavior analysts, they're, from my point of view, they're natural to fill that gap between pediatrics and mental health, and to do it in an evidence-based way. Not a lot of psychology is truly evidence-based. There's an evidence base there, but I'm not so sure that it's so much more eclectic than behavior analysts doing this for a living. Families coming to a behavior analyst doing behavioral pediatrics, I want them to know, and I'm pretty sure they would know, that they're getting science-based services, because it's effective and it's efficient. It's not 3 or 4 years of weekly talk therapy, for example. Sometimes that's needed, but that's not what we do.
I understand.
Yeah.
One of the things that's cool about the book is that you spend some time laying some philosophical groundwork before delving into practical examples of how this works in this very much applied setting. And I would draw the listener's attention to chapter 2 in the book in particular. I want to read you a quote that you cited from a psychologist, Robert Woodworth, and I want to ask you why you put it in there. But this is great. So here it goes. Instead of memory, we should say remembering. Instead of thought, we should say thinking. Instead of sensation, we should say seeing, hearing, etc. But like other learned branches, psychology is prone to transform its verbs into nouns. I love that. The quote continues. Then what happens? We forget that our nouns are merely substitutes for verbs and go hunting for the things denoted by the nouns. But there are no such things. There are only activities that we started with, seeing, remembering, and so on. We have continued to make this mistake for a century. That's just,
Yeah.
I think intuitively behavior analysts will see that and be like, yeah, that makes sense. But I think it's a good thing to recall periodically. And so I guess the thing I'd like to ask you about is, why you felt that was necessary to put that in so starkly, and maybe to comment more broadly on this, this sort of reification of psychological terms, if you will. And I think we're seeing this a lot these days as well. When you see things like pathological demand avoidance and other sorts of things that are coming down the pike, and it's like there are these conditions that exist within the individual and not repertoires and things like that. So can you talk a little bit about that quote? I just loved it, and I just, for no other reason, wanted to share it with the audience, but I'd like to get your thoughts behind it.
Fill the rest of the podcast with this.
no doubt.
Hours on it. No, I mean, in a nutshell, I can say that, I really enjoy how we can easily distinguish what behavior analysis services are in its various forms from traditional mental health. Traditional mental health, I should just state right off the bat that is demonstrably inferior in many ways to behavior analytic services. We measure progress, for example. They tend to not. And keep in mind, I'm a psychologist saying this, right? So I've got a foot in both camps. So I know both well. I want more psychologists to do this too, by the way. This isn't just behavior analysts that I would like to read the book. I'd love for a lot of child clinical psychologists, for example, to read the book. And if they're not already doing solid services, as far as science-based, evidence-based, I'd like for them to. Because the more the merrier doing this stuff. That's really the big point of the book is I'd like for more people to do science-based services for these families because they need it and deserve it. They haven't been getting it, But anyway, that's all behind that's my thinking, the context of the Woodworth quote, why I put that in there. I mean, that was almost a century ago that he wrote that, and no one read it, I guess, because that's what traditional mental health is all about. It centers around hypothetical constructs. I talk a lot about ADHD because that's what most children, children who are diagnosed with anything in mental health are most of them are diagnosed with ADHD. It's like 10% of the population, right? And what is that? Having a diagnosis like that, I'm not saying that it's entirely useless because it is useful. We can predict things with and without certain treatments going forward and things. There's research, good reasons as far as research, as far as, categorizing and profiling behavior, things like that. But I mean, as far as using hypothetical constructs like DSM diagnoses as an explanation for the clinical phenomena, that misleads. That's, in my view, one, if not the primary reason why services are ineffective is because once you diagnose it in traditional mental health, that is the explanation. And now the analysis is done, you see. And behavior analysts see that as a starting point. Yeah, you can profile it, you can categorize or characterize. This is verbal behavior is all a diagnosis is. It describes, but it doesn't explain. Now it's time for behavior analysts. A lot of kids come to me with a diagnosis, but now it's my job to solve the problem. So a diagnosis might be a starting point if we use it at all, you see. From there, we have to figure out, how remote history, that's a lot of you and I've talked about that, what Camille and others are talking about now in terms of trauma-informed therapy as it relates to how it can be used in behavior analysis, thinking about the effects of remote history, but also current circumstances, learning history in general, but current circumstances, effective directive delivery, and all kinds of things. How do we solve this problem? Another way to say that is, and I say this to parents when I meet them, is, if your child is diagnosable with something like ADHD, my job is to make him or her less likely soon to meet criteria, you see. And it's not just whether it's diagnosable or not. It's a question of solving problems and improving functioning, obviously, right? But when it comes to this discussion of the role of diagnosis, calling it something, categorizing something doesn't help me understand it. That's what the analysis and behavior analysis is about.
Hey everyone, as a BCBA, meeting your continuing ed needs can be challenging at times. That's why I have made selected episodes of the Behavioral Observations podcast available for Type 2 continuing education credits. That's right. You can meet a portion of your professional development requirements on the go. Currently, we have CEs for topics including functional assessment, ethics, and supervision. Come learn from podcast favorites such as Greg Hanley, Pat Friman, Mark Dixon, as well as many other amazing guests. For more information, head on over to behavioralobservations.com/getCEs. I can't remember if it was in that. It's been a while since I actually read that chapter. Yeah, again, we've been planning this for a while, and I read it right away, and then a couple of months passed by. But I don't know if it was it. Did you talk about the chemical imbalance hypothesis? I know Pat and I talked about that a little bit in the interview I did with him a couple months back. I see you nodding there. So if you could talk a little bit about that, because again, we mentioned it briefly in my conversation with Pat, but this is something that just pervades the culture, and it's such so any chance we get to do a little bit of myth busting on the podcast, I'm down for it. So can you describe what the chemical imbalance hypothesis is, or if there's a better name for it, and more importantly, what it isn't?
Yeah. So when you talk to just, families, but also an awful lot of medical and mental health providers, they kind of go to that. It's a chemical imbalance in the brain. I'm an evidence guy. I want evidence. I'm philosophically skeptical about a lot of things. I want to understand it and be able to predict it. And how do we diagnose a chemical imbalance? Is this something? Is this just more verbal behavior, or is there science behind this? And it turns out that there's not a whole lot of science behind it. And in fact, there is science showing that the only chemical imbalance that exists in terms of mental health is once you start a psychotropic medication, that part of the reason to give the medication is to create an imbalance that the brain then, with some of them anyway, and this isn't my area, but I've got just enough information to be able to talk a little bit about it. But that's what the psychiatrist is going for, is to create a chemical imbalance to then allow the brain to adjust for it. But as far as, chemical imbalance as explanation for problem behavior, that was just somebody's idea, and it caught on. But there's no evidence for that in truth. In fact, it was a metaphor. That's another thing you see in the literature on this is it was used as a metaphor, but then after a while, medical schools forgot to tell residents that it was a metaphor. And so they go into practice, and then they're explaining this to their patients that, it's due to a chemical imbalance, and then that's why we're going to use medication or whatever. You see, it's not your fault, it's chemical imbalance. Well, it's not their fault, and it's not a chemical imbalance, right? It's just one more in a series of theories that human beings have come up with to try to explain human behavior. And it's just one more that we need to discard and move forward from.
I see. And I should pause and just state, just like I did, hopefully clearly in Pat's episode, that we're not making any recommendations for or against taking or discontinuing medications. If you are taking these types of medications and you're happy with the result, don't let us screw it up. So this is not medical advice or anything like that. We're talking about at least just, the understanding of where the research stands at this particular point in time. And it's so don't make medical decisions based off of two guys talking on a podcast. That's just not, it's probably not good. That's probably good life advice just in general. And in particular in this case. So again, I just want to state that abundantly clearly, or as clearly as I can. So, all right. Thanks for walking us through that. I appreciate that. I know it sometimes can be a touchy subject. I know tons of people on medications who are doing great with them and have had great outcomes. So again, I don't want this to serve as a nudge in any one particular generation.
There's a role for them. There's a role for medication. Yeah. It's just that, again, I represent primary care out here, and gosh, wouldn't it be great if we could solve some problems without even thinking about chemical imbalances?
Absolutely. Yeah.
Once Kids come to me and they're on medication, I don't try to talk them out of the medication. That's not my role. My role might be to collaborate with the prescribing physician and try to figure out kind of, what's the treatment plan overall between interdisciplinary professionals here. But there's a role for it. It's just that, gosh, I'd like to solve a problem without it if we can before we even talk about it.
Well, I think that makes an excellent segue. So let's get into it. Let's walk through a typical case. Let's say you have some, you've got the blazer on. You're ready for patients later on after this podcast. Let's say someone comes through the door. They're a new client or patient or whatever you call them, and
I call them clients.
All right. Okay. So you have a new client. Walk us through what that looks like in terms of how, the intake process in general, and how do you determine what the specific challenges are and how you might conceptualize and implement treatment.
Okay, so here's how I do this. And maybe there's another book, that I need to write, that would help with the business or the process aspect of doing this for a living. That wasn't what the one book is about. But that may be another book I'll write soon. It's needed, I think. But in a nutshell, this is how I do this. I rely on technology heavily on the front end. I don't have a secretary working for me. So I use, I guess I could say, simple practice, which is there are a lot of various offerings out there, online services as far as scheduling and billing, those kinds of things. That's the one that I chose. And it works well for me. There are others. But what's nice is that when people seek my services, they come in through the website. So they click Become a Client. There's a screener questionnaire there of about maybe 15 questions. These are questions that if I did have a secretary working for me, then that person would ask all these questions to see whether or not they would be an appropriate client for me, or if we need to say, you know what, no, it sounds like you really need this other person here to do this or whatever. And so when they fill that out, it comes to my inbox. It's how I set all this up. And then I can read through that, their answers, and then I can decide whether or not I want to take the case or not. If I don't take the case, well, then I reach out to them and I explain why, and I try to give them some direction in terms of where they need to go otherwise. The vast majority, though, I'm able to take, I think. And so then what I do is the second registration process. I'm trying to do this in an efficient way because this could be boring for some listeners, I guess. But then what I do is I send them a link that takes them to their account within my practice. And that's where they fill out, it's all digital and online, but they fill out the consent form and those kinds of things. And I really use, and I put this in the book, I really use a lengthy online questionnaire because I want to collect as much information up front so that I can really study that history before I even meet the family. And when I get that, then I reach out and I schedule them for their initial visit. And that can be in person here in Jupiter, or we can do telehealth as well. And that first session, I've tried this lots of different ways, but the best way to do this, I find, for a lot of reasons, is to just have a parent meeting first. I don't take any insurance, by the way. I used to, and I've gotten away from it. Not taking insurance, there are pros and cons to both, but not taking insurance frees me up considerably to just practice the way I want. I don't have to, fit people into certain codes and procedure codes and diagnosis codes. And that's another thing we can talk about too, as far as behavior analysts and going through insurance. That's a good set of questions.
Yeah, we'll come back to that in a little bit, but I want to hear the process still. So let's.
You bet. So I have a parent meeting first, and that first, and these are all 50 to 60 minutes in length. So the first meeting is a parent meeting, and when I meet parents, I want to put them at ease. I want them to know they're in good hands. I want them to be hopeful. If there's anything I can do, if there's one thing I can accomplish that would be really helpful to them and me in helping them, it would be to instill some hope, I think. And to give them a little background in terms of the approach, what are they walking into? I try to put some of that on the website so they know what they're signing up for. But then, I really want to explain kind of how I think about certain things. Like, for example, I usually list the meta factors from the book. Sleep, these are like the buffer things like sleep and cooperation and being able to use language effectively as far as, self-advocating and things like that. Kids need to talk to us rather than show anger if they don't like the situation. Just they should be able to talk to us. And so I explain all that. And then we schedule the next session where I meet the child. And, as long as they're within about a 3-hour driving radius, I really ask them, can you please bring your child to me if they're on telehealth otherwise? Because I just want to hang out. And when I meet kids, Pat Friman had said something a long time ago. He probably has been saying forever, but really resonated with me. If what you're doing looks and sounds and feels like therapy, you're probably doing it wrong, and you're probably going to be less effective, right? I've always kept that in mind. When I meet kids, I want them to see this as a good thing. I want them to have some fun. I pull out the ukulele and do some stupid magic tricks just to see how they respond to that, and whether or not, if it's a 3 or a 4 or 5-year-old, whether or not they, ask to see it and play with certain things, or if they just grab for it, right? Because, if they're not manding very effectively or at all, well, then that predicts some problems with, classmate issues in the classroom and sibling rivalry or sibling conflict. I learn a lot in that hour with the child. The third session, I go back to a parent meeting and I have some last minute questions in almost every case that I want to ask. And then I switch gears and I go into treatment planning. And treatment planning for me is kept kind of short and sweet as far as, it's not a big drawn out form. I just want to get together a punch list. I want the parents to essentially tell me, and we need to agree going forward as to exactly what we're here for. What are the things that they want change with? For example, bedtime. If bedtime is an issue, then we'll put that on the list. Compliance rate, I put in the book, I'm looking for at least a 70% compliance rate upon first request. Most kids coming to me are 0 to 10%, right? Imagine, and that's one of the reasons why I meet the parents first, because I like to say things like, well, you know what, you gave me a 0% compliance rate for your child. Imagine if we could snap our fingers and now your child is at 70% or 60%, right? What would that change in family life? And they always swoon and go, man, that would be nice. Right? So just, having them really kind of see where we could go with all this. And so anything, going back to the third session, talking about treatment planning, anything that they told me on the questionnaire, I'm coming back to, and I'm saying, well, how about this? How about this? And usually there are about 7 or 8 targeted behaviors or targeted outcomes. And we agree on that. And then I try at that point to take a few minutes and say, you know what, let's assign a value to each of these, maybe on a scale from 0 to 10, right? 0 is as bad as can be, and 10 is as good as can be, no concern. Not perfect, but no concern. And so I establish a little baseline there. And I do that because I want to collect some data, but I don't want to get bogged down with the data collection, you see. And not only that, but that way of doing it, the Likert ratings, tends to be a really solid way of looking at social validity and satisfaction with services. So it works for me. But then again, there's also, like, if we're treating enuresis, I'd like to know how many nights, like, for example, nocturnal enuresis, I'd like to know how many nights the child was wet or dry. And I ask them to keep a little diary and then bring it in or email it to me right before we meet. And so that wouldn't be a Likert score. That would be a rate, for example, how many times this week. It's frequency count, maybe. Okay. So, and certainly with like moments of aggression, tantrums, meltdowns, I want to get a good baseline on all that, because I also, by the third data set that I collect, intake is the first data set. So by the third data set, I routinely begin to graph this and share that with families. And boy, I get a lot of mileage out of doing that for a lot of reasons. It allows me to reinforce their efforts, because, if the graph goes from bottom left to top right pretty quickly, then that tells me that treatment adherence is looking good, right? They're on. And if it's flatlined, well, gosh, I blame myself first. I need to see if I'm conceptualizing this correctly, or maybe I start asking about treatment adherence, then I help them with that. And so the first run up, or just kind of the last piece here, is that the run up of 3 sessions, the first 3 sessions, that's the run up to kind of get my bearings, and we get our treatment plan and our data plan, and then we're ready to rock and roll from there. And then from there, I usually meet with families. It depends on the situation. If it's a preteen or a teenager, I'll have them back almost every time after that to be a full participant. If it's a child, maybe ages 1 or 2, all the way up to probably about just elementary age, like up to about 8, 10, 11, somewhere in there, I may not see them again. I might bring them in on the last one to give them a big high five and brag on them a bit, and show them the graph too. Like, you've done really well. And, kind of close the loop on that. Depends on why they're here. Another reason why I would have children be more of a part of the process is kids of any age with anxiety, but their cooperation is good because they want help. Usually, when there's non-compliance, when there's those kinds of kind of behavioral issues, tantrums, meltdowns, there's not much you can do with the child therapeutically. You've got to help the parents know how to handle that as if you were there and you were doing it. See that? So I'd say probably 90% of what I do as far as therapeutic work is parent training, just solid parent training, just giving them the protocols that I've developed for these things, dialing them in. The protocols are a starting point, dialing them in to further tailor to the situation, and then just use solid behavior analytic principles to continue to dial in until we get to where we want to be. And the average run is about 7 to 8 sessions.
Regardless of your title, if you are a behavior consultant who is working in or with schools and you are struggling and wondering why your interventions are not producing the desired results, you are not alone. Unfortunately, those tasked with improving behavior in schools are too often left to carry the burden by themselves. You are the behavior person, so you take care of it, is the unsaid mantra. But you can't improve behavior and the associated outcomes by yourself. In fact, creating sustainable improvement in student behavior almost always requires changes in the performance of the educators. I'm Dr. Pauly, and along with my colleagues Anika Costa and Matt Sikoria, we are designing coursework called the Behavioral Toolbox. In it, you will be taught strategies grounded in organizational behavior management for consulting in schools in a way that brings out the best in educators so they can bring out the best in the students they serve. If this sounds exciting, be sure to click on the link in the description to sign up for more information.
There's a lot there I want to get into. I guess the first thing, I was given some what I thought was really good advice by a supervisor of mine one time, and it was when I was starting to do some in-home work, and we were doing typical ABA stuff, but we were also managing kind of mild behavior problems and things like that. And with regard to the latter, my boss basically said, when you're trying to pick a particular behavior problem to prioritize, go with what the parents say is the most important to them, even if you think there's something else that's more important.
Yeah.
And I thought that was good advice. At the same time, I've seen times where, the parent might be reporting, mealtime or something like that, but the kid does not sleep and the kid's just a mess because they're, up all night. They're in and out of mom and dad's bed, yada, yada, yada. And so I'm curious. So I've gone back and forth in terms of adhering to that principle over the years. Have there been times where you've had to guide parents towards what you think might be a more important target behavior to work on, even though they might ask for assistance with something else? Or is it the case that you want to go with what the parent is reporting as most significant, because then you get an instantaneous fan? And
right.
Can you talk about target selection there from that perspective?
So that's a good question. I would say that one of the functions for me of the first session with parents only is to explain the metafactor concept, which in other words, there are some things that we need to make sure that these are the fundamentals. These are the things that we got to make sure that, we're addressing first. So I already plant that seed by the time we get to the treatment planning session. There are some other considerations here. Another consideration here is sometimes you want to pick one of the easiest to solve, especially through parent training, right? And
yes, I've heard that. I've heard that philosophy before as well. Yeah, go ahead.
You bet. Yeah, and you get that momentum, and you get optimism and hope on the part of the parents, and likely more treatment adherence going forward because this is doable. But having said that, though, my job is to help get parents from start to finish as efficiently as possible. I'm always available after them if they want to come in and talk about anything. And, we can slow down our pace once we get to the end zone with that first course. And I tell them that up front. I want to get you from A to B as quickly as possible. And I'm asking for your trust in my judgment. But at the same time, if you have any questions or concerns, please voice them. And you can even email me in between sessions and let me know so I can know where you are on these things. I'm here to serve you, right? So, but generally speaking, if sleep is suboptimal, and I explain that in the first session that, sleep is pretty important. And if we can shore this up, I think that's going to get us a snowball effect with everything else we're doing. That's usually compelling to parents. I do ask them when we do our treatment planning after we get the list. Then I ask them, what's most important here for you? I almost always ask that question because I want to know where they are with this. And sometimes they surprise me. Oftentimes they don't, because we're in agreement already on what's most important here. But sometimes they say, you know what? Sibling conflict is driving me crazy. So I really need help with that.
I'm laughing because I've got 3 kids and my 2 youngest are in a phase right now where it's just one of those things. It's just, they can't get out of each other's way. And so I certainly resonate with that one for sure.
Yeah. So I want families when they leave my office every time or when we log off on telehealth, I want them to just know that I've been listening, and that I'm here for them and I'm going to do my very best for them. If they don't think that I'm taking their priorities seriously, then I don't think I'm going to get the outcome I want for them. So I'm always considering what it is that they're here for and kind of how they're looking at this process. And I try to find a middle ground there so that we're always efficient and effective.
You're what's, I guess, I didn't really think about this when I was coming up with some of the discussion points, but inherent in all this seems to be the necessity for a real solid set of soft skills.
Yeah.
To be able to establish rapport, to be able to, kind of guide people in the right way to the point you just made, to convey that someone's heard, they're listened to, and so forth. So I think that's a really, really good point. I'm glad you brought that up. So you mentioned caregiver adherence a bit ago, and I'm imagining with someone is, I think there's some choice Freud quotes related to this, but if someone's private paying, there's a motivation to solve the problem, right? And so you might have some motivation built in, I suppose, as it relates to treatment adherence. But people at the same time have a lot of things on their plate and whatnot, and even though they might be spending their own out of pocket money for this type of service, they maybe they don't get to do the bedtime routine or implement whatever the intervention might be. So could you talk about navigating parental treatment adherence?
Sure.
How do you if you do think that that's a problem, how do you go about solving that?
Mm-hmm. Yeah, there's a lot to talk about there. One thought I'm having here is that, like you said, who's paying for services and does that have an impact? I think that, especially with mental health, I think that it's just a kind of an assumption out there with families that you farm that out. Parents don't have any active role to play. You pay for it or you have insurance pay for it. And then the doctor does whatever the doctor will do to solve the problem. that's another reason why I have that first parent-only meeting, because I want to explain all this to make sure they have it. Another thought I'm having too, before we get into like real kind of how to solve treatment adherence problems or prevent problems with it, is that there's some research, there's some evidence out there that shows that parents need to have this is a question of who's paying for it, right? Families need to pay something, even if it's $5, because then they've got some skin in the game, I guess. They've got some ownership of the process and the outcome. And so whenever there's a situation like, I like to offer some pro bono services occasionally, but you know what? I'm not going to do it for free. I'll do it for $5. You know what I mean? Because you got to follow the science on this stuff. And that's what I do. All right. Now, as far as treatment adherence generally, I think it all starts, and there's a lot of literature out there on this, and I put a whole chapter in the book on this, but I think that first off, let me bring up Pat Friman again. He wrote a book, wrote an article talking about the fundamental attribution error, right? And I think about that with treatment adherence too. It's, behavior analysts are human beings, and sometimes we got to flip that switch in our brain, in our mind, in terms of like, I need to think behavior analytically here. A great example of this is treatment adherence. If you as a behavior analyst are offering parent training, consultation to families or teachers for that matter, and you say, this is the procedure that's going to help solve this problem, and they agree to do it, they commit to do it, but then you find out a week later or 2 weeks later that they haven't done it. It's natural for us as human beings to say, well, what the heck's going on there? It's like, why didn't they do it? Maybe they weren't interested as much as they said that they were interested in doing it. Or, maybe they're, like in the literature on this talks about how, we think that people who don't follow through are just, they're just kind of lazy about it. Those kinds of things. In other words, we're attributing some personal characteristics, when in fact what we should be doing is thinking behavior analytically on this. And that is that, I need to take responsibility for implementation, even though I'm not the implementer. They're the implementer. But if I this is an extreme ownership thing. if I can accept and commit to treatment adherence, this is I'm in charge of this. And so I need to make sure that I program for high treatment adherence on the front end, but also communicate clearly and have some procedures here set up for the family that if they're having problems with implementation, that they need to reach out to me, and that's not only welcomed, I'm kind of requiring it. You know what I mean? Like, you're not bothering me if you reach out in between sessions. I'm here for that. It's built in to the model. You see, it's not just session and that's it. We just, you just have a session and that's it. We're a team. And it gets back maybe to the soft skills that you were talking about. But you have to take responsibility as a clinician, as a practitioner, for treatment adherence.
Let me stop you right there real quick, because I'm going to channel the audience member here, and they were like, well, Chris, come on. I don't have any control over the home setting. I've done my best to explain what the correct form of treatment is. I've, used all my soft skill repertoire. I've treated the client and the family unit compassionately, et cetera, et cetera, et cetera. So in what way can I take ownership of this? How is that possible?
By knowing there's always something that you can do.
Okay.
Maybe put it that way. There's a tidbit I found in researching for the book that I put in the chapter on this. Just one of 1,000 things that could possibly be said about this is that when you have the family back in and you talk about treatment adherence, like, how have you done with implementation? And they say, gosh, it's been a crazy week, and I wasn't able to get to it, or I totally forgot when I got home because we were so busy. It's human nature for us to say, it's okay, it's all right. But one of the recommendations I found in researching for the book is that you don't want to do that. You don't want to say, right? You want to say, okay, well, let's problem solve this for next time. You see, you don't want to give them permission to do it again.
Okay, so you don't want blanket compassion so compassionate that it's so compassionate that it provides blanket immunity, essentially.
Totally, yeah, exactly.
Okay.
Like you only have a 60-minute session goes fast with a family, and you can't waste a lot of time placating, when it comes to treatment adherence. Listen, without treatment adherence, any approach that really involves parent training is doomed to fail. Treatment adherence is what makes you successful as a clinician, especially in behavioral pediatrics to a large extent. So, this is serious stuff, Now, you want to use those soft skills, and you want to be influential, and you want to maintain rapport with families, because that helps with treatment adherence. You don't want to turn them off or blame them. The question always is, how do I engineer for success here as a behavior analyst? And that might even include sitting down with them. This is something that happens a lot. When I glance over here, I'm looking at my couch because I'm picturing the consultation moment. Parents are not behavior analysts. They don't think like we do as far as, how to solve problems. And so, my job with low treatment adherence might involve, and sometimes it actually usually involves, if it's an issue, helping the parent re-engineer their home environment for greater adherence. That's part of our job, is to engineer for generalization. And that's what treatment adherence is engineering for generalization and maintenance, right? So if we think about it that way, well, then that opens up, an awful lot of possibilities in terms of what we can do process-wise with families. We could even have them, if treatment adherence is low 2 sessions in a row, and they're still committed, they're not just going to say, this isn't working for us, but they say, no, I want to be successful, and I want to do this. If they're giving me that tells me that it's probably something that I'm doing wrong, or, I'm doing something insufficiently. Like, I need to make sure that they're as supported as possible, conceptually and procedurally. Handing them written protocols is better than just talking about it, so
Sure.
they can take it home. Emailing them protocols so they have it and they can always go back to it. There's always something that we can do to help. And in the end, you want to be successful as a clinician, and you want that parent, I'm running a business here. So, in the end, gosh, I want to be successful, and I want parents and families to be successful. And I'd like for them to naturally want to tell 10 more families about me, right? If I don't get treatment adherence, I'm not going to be successful, and neither will they. And in fact, they might be saying other things to other families, right? Not just, you need to go see this guy, right? Treatment adherence is the fuel for the rocket.
I say, well, thank you for the pushback on that. I just had to voice what I thought would be a common response to taking ownership for things that are less directly under your control. So you've given us some good things to think about. Are you looking for a new job, but you're overwhelmed with all the emails that you're getting from various ABA agencies? What if there was someone who was in your corner and could help you find the perfect job placement? Well, that person exists. Barbara Voss has been working as a recruiter for over 30 years, and her company, HRIC, specializes in placing BCBAs in permanent full-time positions throughout the United States. Barbara has been placing BCBAs since 2011, so she knows our business, and she offers personalized service to any BCBA looking for a new position. She also helps companies looking to hire BCBAs too. Here are just some of the things Barbara can help you with. She can provide information about salary ranges in different markets across the country. She can help you write your resume. She can coordinate and prepare you for the interview process, and even help negotiate the right salary for you. And best of all, there are no charges to any candidate for all of these services. When you're ready to make a change and want to work with someone who will listen to you and understand what you need in a new position, contact Barbara at HRIC. To schedule a confidential discussion, head over to hricolorado.com. Again, that's hricolorado.com, and hit the contact button to connect with Barbara. You won't be disappointed. One of the things that Pat brought up, and of course you brought up in your talk at ABAI, and you alluded to a number of times here in this conversation, is that the behavior analysts are in a good place training wise to explore this as a career option. Pat mentioned it kind of off the cuff and the way in which Pat does. and we were under some time constraints. And there's a topic that I wanted to get into with him on this that time didn't just permit. So I'd like to get your thoughts on it, since you guys seem to be coming from a similar point of view. And that's this. So saying that behavior analysts should, kind of like hang out a shingle and offer primary care behavioral pediatrics as a service. And we'll get into the reimbursement piece, I suppose, in a minute. But there no doubt, and I'm surprised I didn't get email on this. I was shocked I didn't actually when Pat mentioned it. But again, he mentioned it kind of quickly, so maybe that's why. But I am have friends and colleagues who are quote unquote real psychologists, like, well, of course, like yourself, but also might be licensed, maybe like MSWs, licensed clinical social workers, master's level psychotherapists, if you will, not just, licensed clinical psychologists, but, these are people who have extensive clinical training and all sorts of things, beyond, behavior analysis. And so they understand like family systems, they understand risks to clients and when to refer and things like that. So I'm curious what your thoughts are in terms of if we were to have, let's say, okay, what's there, 65, 70,000 BCBAs running around out here. And let's say the next 10,000 of them, I'm just, making this up, but, go into primary care behavioral pediatrics. Would you agree that there's some risk associated with that? Especially if, and again, this is more of a criticism of not necessarily the approach of delving into behavioral pediatrics, but might be something having to do with the training. But, we've got essentially an autism-centric type of training protocol, if you will. But even if not, let's say someone goes to kind of an eclectic program, and they learn about, of course, how to support individuals with, significant developmental disabilities, but they also learn about, precision teaching, and they learn about ACT, and they learn about, the EAB and all sorts of other things. And they come out as kind of a well-rounded BCBA. Even still, that clinician might present some risk to a client, I suppose, if they don't know, absent of any other training, I guess what I'm saying. So yeah. How do we, I guess two questions from this, and I apologize for the long wind up here, but I've been thinking about this a lot. And I want to make sure I frame this correctly. I guess, A, do you agree with that characterization? And if so, how do we mitigate that risk?
Well, the first thought I'm having is that pseudoscientific and unscientific practice among psychologists and other licensed professionals out there is a greater risk than well-trained behavior analysts going into behavioral pediatrics who are adequately trained and supported. That's what my mind immediately went to.
Sure. But let's get back to your earlier point about anorexia, for example. Like, you have the background and knowledge and training to know, like, hey, this is serious business.
Yep. And
someone can die if they don't get the right treatment. And I'm not being hyperbolic here. It's from what I understand, it's the most deadly mental health challenge that's out there. Correct me if I'm wrong, but that's my understanding of it. I've got friends who have experienced that directly, and I've got friends whose children have experienced it directly. It's dangerous.
Yeah.
And you have the background knowledge to say, hey, I don't want anything to do with that, because I want this kid to get the right treatment in the right place and things like that. And I presume that understanding has come through some form of training at the clinical level that, that the average BCBA might not have exposure to. Or even let's maybe take a less extreme example. Let's talk about trauma, for example. And again, we'll get into trauma, more specifically, but I'm just using this as a vehicle for this example, I suppose. Yeah. That, someone might have experienced like some horrendous adverse childhood experience that and if we're like, oh, well, I'm just going to set up a DRA and extinction, or what, I'm just making stuff up here, but, because that's what the literature said for this, perhaps, and this is what I've been trained in, where the proper treatment would be to, refer someone to more, specialized interventions or something like that. So again, I'm using very extreme examples to gently push back on that here, but just, again, I guess I interrupted my response with my yeah, but I'll allow you to continue here with your thoughts on this.
No, these are all great questions. These questions need to be considered as, this is kind of a new thing, to have behavior analysts know that this is a career option for them. To my knowledge, I don't believe there's any course sequence in any graduate program in behavior analysis for behavioral pediatrics. I know that there are high quality internships and postdocs that are available, but not a training, not a course sequence, right? They don't exist right now, and my assumption is they don't exist because this is kind of new. They didn't exist before for psychology or psychiatry or neurology, right? So I think it's coming. That was another reason I wrote the book, was to kind of see if I can spark that. Now there's a textbook to use that you can build maybe a course sequence around. This is a function of good training and support and mentoring and having podcasts like this, that people can go back to and just if you're interested in doing this for a living as a behavior analyst, there's increasing resources out there for you to access. It's still not enough. I'm doing my part, just trying to keep building resources for folks who want to do this for a living. Listen, the last thing I want is to have anything to do with behavior analysts going into behavioral pediatrics and doing it in a terrible way, unethically, ineffectually. That's not what I want. I want people to be adequately prepared and to continue to learn and develop in the profession and in the subspecialty, and to do really, really good work. And questions like yours here, Matt, these are really good questions, like I said, because we need to anticipate these situations. There's a part in the book on referrals, and that's something that Pat had written about for years, on what behavioral pediatrics is. It's when you really get down to it, it's really about kind of three avenues of intervention, and that third avenue of intervention behind prescriptive behavioral treatment and supportive counseling, like ad hoc short-term counseling, and really for treatment adherence, when you really get down to it. The third is referral. Referral is a treatment avenue. It's like, I'm not the one to do the treatment, somebody else.
Okay, that's good.
So
I never thought of it that way.
We want to make sure that that families get what they need, but in order for that to happen, we need to make sure the practitioners know to do it.
Good point. Thanks for entertaining me. And I would agree that, like, for 90%, maybe higher of cases, behavior analysts are uniquely suited for this type of work, for sure. So I'm not throwing cold water on the.
No, I didn't take it as that.
So let's get back to the concierge part of this. Sure, we'll get a lot of feedback on that. I think the idea of practicing without insurance is something that is like a dream come true for many listeners here. But practicality wise and access wise is something that that came to mind when I was thinking through this question. So when you say a concierge service, it kind of conjures up images of the lifestyles of the rich and famous. And for those, maybe people just, our age and older might know what that means, but I'll put a Wikipedia link, I suppose, to what that show was back in the day. I think was it Robin Leach, I believe.
Yeah, it was. Yeah.
But anyway, so I'm curious what your thoughts are on, taking kind of essentially a cash only business, if you will, and your thoughts on, the extent to which that does or doesn't restrict access to care. So yeah, I've got some perhaps other thoughts on that, but maybe let's just start there in terms of just from a standpoint of care access and whatnot.
You bet.
Yeah.
So everything is a trade-off, right? Taking insurance, you're going to miss some people because they don't take that, or they don't have that particular insurance, right? A lot of times when you take insurance, in fact, I know this from having taken insurance in the past, you end up having such a demand that you have a problem with capacity. And some people need to get in right away. I mean, a lot of times, that's what primary care is really all about, is being able to get to it sooner rather than later. right? But if you have a 6-month wait list, then, who are you serving besides your current clients? You're not really serving that function sometimes. And again, everything's a trade-off. It was a business decision and a personal decision on my part once I realized that I didn't need to take insurance to not take insurance. My life just has become exponentially easier. It's more cost productive, or it's not cost prohibitive for that matter. It's overhead is much lower, revenue is higher, and I can offer a more personalized experience for every family who comes to me. So really, there's an inherent tension, I think, between quality and quantity when it comes to how services are being paid for. Not taking insurance, but taking self-pay, quality can be higher because I've got more time to answer emails in between or call clients back in between sessions. Taking insurance, you're paid pennies on the dollar as far as what your services are worth. And so, you can kind of find yourself on a treadmill trying to keep up in order to pay the light bill and to pay your health insurance and things like that, your own health insurance. And, days just, kind of go by having seen, 8 to 10, 11 clients back to back. And there's no time to be able to, to get back to clients, like I said, or to do other things like marketing. Again, it was ultimately a business and personal decision on my part to not take it, knowing full well that there were going to be trade-offs there. I want everybody out there who needs services to get services. That's partly why I'm doing what I'm doing as far as, kind of proselytizing behavioral pediatrics, because I need more of me out here to help everybody, you see. I'm at a point in my career where I can't go as hard and as fast as I did when I was in my 20s and 30s. So this model of service delivery, this version of it, suits my kind of natural pace now. You need to go in a certain direction over time, or else you just get burnt out and you can't pull it off. I want to be able to pull it off and to pull it off well. So not taking insurance. And by the way, it's not just, you either take insurance or you don't. You can take some insurances, or you can take all insurances. And then as your demand goes up, and as there are some folks who are saying they'd rather pay self-pay rather than go through their insurance for any number of reasons, confidentiality, for example, that's their decision, I suppose. And so what you do is you begin to whittle off, and this is a good business practice. This belongs in a business book for practice, I think, is if you want to move from taking insurance to not taking insurance, well, then you can choose which of the policies that you accept, or not policies, but plan, or what commercial insurances you take. Pick the one that's reimbursing you the worst and just drop it. Of course, there's some red tape there. You have to wait 3 months or whatever once you announce. But nonetheless, though, you can begin to kind of taper from requiring that, and just making sure up front that everybody knows what they're getting into. If you have this insurance, I don't take that insurance, so you'll be self-pay. You want to make sure that everybody understands what's going on there, what they're walking into. But I got to tell you, being a self-pay practice allows so much more leeway, and I'm more relaxed as I meet with each family. I'm more accessible to them. And it's not only how it's paid for in terms of what a concierge practice, at least in my mind, is. It's also just the overall experience. It tends to be a more kind of exclusive office setting. I serve espresso, for folks who want espresso. That's free of charge. That's built into the fees, right? I want this to be a wonderful customer service experience for each family. That's really what I'm going for. Is I want this to be the best experience that they could have imagined. And so anything that I can do to give them that's what I'm striving to do.
I'm sure all those little touches go a long way towards all the other aspects of this in terms of, get back to treatment adherence, et cetera. So the whole environment is, reinforcing on a global level. Hopefully that there's some value add to that from as it relates to getting people to do things that you're asking them to do that may be tough. Yeah. So and also you did mention something like you want everyone to have this. And I guess the reason why I asked this question is I serve a lot of communities that are very, very disadvantaged.
Yeah.
And I'm trying to, and these families desperately need this type of service. And the reason I know this is because I work with their kids when they come into school. And so if you have a kid with a repertoire of challenging behavior and at home and, tantrums and doesn't share and, kind of, gets that doesn't understand limits, doesn't understand the word no, they're going to bring those repertoires into school. And that creates all sorts of challenges. And a lot of times I end up talking to parents as part of doing an FBA or something like that. And, kind of I've got a bit of a window into this, but it's kind of like, my wife's a high school English teacher, and the parents who go to parent teacher night are usually not the parents that you need to see.
That's true.
And so the concierge aspect of this, that comes to mind when I'm seeing some of these families that are struggling and are very likely on Medicaid, et cetera. And I'm just I'm not asking you for the answer to this because obviously you've come to your own conclusion about how this might work. But as more generally, as we're expanding if we want to expand this practice of primary care behavioral pediatrics, that's a problem I think that needs to be solved in terms of equitable access.
Yes. No, I agree. In fact, let me say this too. I had the opportunity to serve BoysTown again after I did my internship with them. And that was as a clinic director for the BoysTown clinic here in West Palm. So BoysTown has satellite places around the country. One of them has been the last 35 years or so here in West Palm Beach, just down the road from me. And so I was brought on as the person to start the clinic for them. And I was the director for 5 years there. And I asked them up front, how would you like to set this up? We could take all insurances and Medicaid. And they said, that sounds awesome. That's what we'll do because we want to maximize access for anyone who needs services. And I thought that was a fantastic idea. So we did that. What's nice is that after 5 years, I decided to move back into private practice, but that clinic is still going strong. And so I feel really good about that, where, pediatricians who send to me, they know that I don't take insurance and they're looking out for their patients and patient families. And so, if somebody is, on Medicaid, for example, then they want to make sure that they get services and they know to send them to BoysTown and not to me, you see. So you have to be part of the community that you're in as a practitioner. And you want to make sure that everybody, you want to work with everybody in town to make sure, especially referral sources, because when you really get down to it, you don't want all the referrals. You want to make sure that the referral sources know what the considerations are to make sure that every family gets what they need. And that's ultimately what I want. And that's why sometimes I don't take clients, right? I don't take some families because they answer some questions in a way that I know that I'm not appropriate for them, but I know somebody who would be, or some options for them. So I agree that's an issue, making sure that everybody gets what they need, for sure.
Got it. Chris, I've held you way over the time we allotted here. I do have a few more questions. If you do have a little bit more time, we can get into. If not, we can put a pin on this and do a part 2.
Yeah, no, I'm good.
All right. And we could do a part 2 anyway. I'm sure we'll get a lot of questions out of this episode. But all right, so I'll plow ahead here. All right. So this is something that a little, we talked about this a little bit here and there, but so I noticed you've been, I've seen it online. We've talked about it personally when we got to hang out at ABAI. You've been trying to wrap your arms around this this area of trauma informed behavior analysis or trauma informed care, et cetera. And I always like to hear about this from quote unquote real psychologists, such as yourself, who presumably have, extensive clinical training in these types of areas. And, of course, we've got behavior analysis right now. Is, the last 5 years, we've had an explosion of interest in this area. And how do we conceptualize what trauma is? How do we, the extent to which we incorporate the, trauma sensitive approaches into our practices and so forth. So I don't have a specific question other than, again, I know you've done a lot of kind of self-study on this along with your actual training. What have you learned? What do you make of this, like of this kind of, I guess, burgeoning interest in the so-called mainstream behavior analysis?
Yeah. So, I started to notice that behavior analysts were talking about trauma-informed care. And, I guess I should start out by saying that I've learned to be a skeptic, especially with anything that's coming from the psychology quarter.
As a psychologist.
As a psychologist, that's what drew me to behavior analysis, because I wanted something that was, that was established and verifiable and demonstrably useful. And so, again, where do I go to get my CEs? Not, I go to behavior analysis. So, but anyway, when it comes to trauma-informed care, I wanted to know why behavior analysis was trying to import something from psychology land into behavior analysis, because my instincts are to try to move things from behavior analysis to psychology, right? So why are we doing this? What's that about? And so that's why I decided, I want to really understand the function of this. I want to really understand what's going on here. And I got to tell you, I'm at a point now where I'd say I'm probably I'm not quite halfway through reading everything I need to read and talking to people I need to talk to in order to really wrap my mind around this. But some initial impressions right now. Number one, as somebody who's always been behavior analytic in approach, I think I've always been trauma informed in that. I mean, I never thought about it that way before, but I think I've always been trauma informed in that I'm always thinking about the effect of remote history and learning history on current behavior given the current circumstances. It occurred to me that, I have to remind myself throughout my career and my life that not everybody around me is a behavior analyst, right?
It's hard.
I've always thought contextually about things, and I think if you're trauma informed with your individual client, I think that of course you're thinking about these factors. If there was a traumatic event or event that was experienced as traumatic, and there are processes, as far as now I'm thinking about, the kind of the ACT literature, thinking about verbal behavior in general in terms of kind of how we kind of think ourselves into corners sometimes, and that affects our behavior in the moment. All this is really critical. It's part of, I think, an effective and competent functional assessment of what, why a person is behaving this way. I can also say that when I started to see trauma-informed therapy popping up in the behavioral literature, I love Scott Lilienfeld's work. Everything that he's written. He was at Emory and he just passed away a few years ago. But one of the things that he wrote about a lot, and he has a lot of book chapters and books written on basically slaughtering sacred cows, just, debunking pseudoscience, making sure that practitioners in psychology and behavior analysis too, but really his area was psychology, making sure that we really know what we're talking about and that we're not assuming things and doing things that are not true or effective. And one of the things that he's written about, going back probably 15 years or so, if I'm correct on that, looking at, it wasn't called trauma-informed care then. That's kind of a newer kind of label, I think, for that literature. But just, what do we do for folks, adult clients, for example, in psychology or psychiatry for that matter, who are diagnosed with PTSD? Okay, what do we do for those folks? What do we do also for folks who were in a traumatic event very recently? And then what can psychology do for them as kind of an inoculation against the development of PTSD? All of this has been looked at. And I knew this going in, that, because I had read Lilienfeld's work and others on this, where, for example, and I put this in, no, this isn't in the book, but this is somewhere else, something else I read, on critical incident stress debriefing, for example, or psychological first aid, it's called. And, psychologists were doing this, and they were doing God's work and doing it, right? But then when you look at it skeptically, like perform research on this to make sure that it's working as intended, it turns out what they found was that folks who were given that intervention did worse than the control group. That's interesting, right? That's interesting. So in other words, what could be going on there? I think it's probably more than anything else a function of allowing exposure, right? Versus delaying the exposure through the therapeutic process. I'm still looking at it. But I guess my larger point is that when I saw trauma-informed care in the behavioral literature, I was thinking, oh, wait, hold on, make sure I don't want behavior analysts to go down this road thinking that they're going to be effective when in fact they're worsening the situation for clients. Let's get this right. Right. So then the more that I read the behavioral literature on this, I think Dichu
Roger Ruman. Yep.
Right. His work with Hanley and Camille Kolu, really impressive stuff. And, I'm what I discovered, and again, I'm still looking at this, but what I discovered where I am right now in my thinking is that when we say trauma-informed care, a lot of what we're talking about is factors that affect the therapeutic alliance, but also that's maybe antecedent, but then thinking about consequent, the therapy process. I buy that, somebody who has had a traumatic event and has shown, what's kind of colloquially called trauma behaviors, right? Or behaviors that are probably due to that. At least that's how we think about that right now, or how it's being thought about. You don't want to necessarily use unmodified extinction for those kids. You want to do more of a gradual approach. Now, see, all that makes sense to me. What I started with in talking about this is what's the function for us, right? And I think the function, I think it's a good instinct on our part is to really think about social validity, right? Are we doing everything we need to do to couch what we're doing in terms that are acceptable to others who aren't behavior analysts? And is there value to our work? Is there perceived value on the front end to what behavior analysts can provide? I think all this is worthwhile. And I think Camille's work and others who are couching trauma-informed care in the behavioral literature in terms of, how can we improve outcomes? I think is wonderful. And I think we need to continue to do it. But there's always that skeptic in me, that's always wanting to tap the brakes on stuff like this just to make sure that we're getting it right. And just because it's in the psychological literature doesn't mean that it's actually established without side effects, right? We don't want to produce any iatrogenic effects. We as a field, and certainly behavioral pediatrics as a subspecialty, we need to be really mindful about these things and get it right. And so we need to be very thoughtful and careful. That's where I am on that right now. I love what we're doing, but we need to be careful.
Okay. All right. When you get closer to, 70, 80, 90% way through, your study,
I'll get back to you on that. Yeah.
To get back to you, maybe we could do like a round table with you, and maybe if we can get Camille and Ditu or something like that. I think that would be a fun conversation to have. So
yeah, I
awesome.
think so.
Okay. So I got to ask something, the total, change of gears here, I suppose, but I think you're a great resource you probably have a unique perspective on this. So it's hard to, we keep talking about this mental health crisis, particularly in school age individuals. You can't go anywhere these days without hearing like huge increases in things like, in depression and anxiety, particularly in adolescent females. Both are, both males and females, these problems are getting worse, but it's particularly so with females if you look at some of the data that you see out there. From your perspective, I would also say that there's the new book, The Anxious Generation, I think that Jonathan Haidt just put out, that talks about this, and he's got a number of hypotheses, et cetera, as to why this might be the case. But what is your perspective on this? Is this something you're seeing? Do you have any ideas what's going on? Any ideas in terms of what we do about it?
Yeah. So, there are a few things that I could say probably. And one of them would be that when it comes to parenting style, this is something that's part of kind of the first couple of treatment sessions with parents when there's noncompliance and just problems with kind of daily management with routines and things. There is authoritarian parenting and authoritative parenting, and then there's permissive and indulgent, right? Permissive and indulgent parenting, I got to tell you, man, so many just loving, committed parents are scared to actually parent their kids these days. They're afraid that they're going to get in trouble because if they get, their 4-year-old, didn't like the consequence that he got last night. So then he goes to school and he's, a little teary maybe. And the teacher might ask, what's wrong? And he says, well, my mom yelled at me last night, and then, is that a reportable offense or what? I'm not saying that there's necessarily validity to that, in terms of, that teacher will report that kid or report the parent to DCF. What I am saying is that parents these days are scared to death of it, and that affects their behavior. Right. And so not only that, but that's been our culture in terms of parenting for 40 or 50 years now. The predominant culture as far as parenting is very hyper responsive and permissive and indulgent. Since the advent of iPads, the iPad is raising the child, many hours of the day. I'm not necessarily blaming parents, because that would be like blaming the lab animal, in behavior analysis, we say, don't ever blame the rat,
Mm-hmm.
I don't blame parents necessarily because they're a product of their environment and their learning history as well. What makes parent training successful is that we move most families from permissive and indulgent parenting and management to authoritative, meaning loving but firm. And that's not a natural repertoire for most parents these days. Giving them that, I don't know if it's ever been, quite frankly, because it's either authoritarian or permissive, and the authoritative is probably the hardest to find in nature. Like all in all, I think that opposites determine meaning, and so if you were raised in a certain way and you didn't like it, then you say, well, I'm not going to do that to my kid. Sure. And then you completely to the other side. We keep missing that golden mean, the golden middle. And that's authoritative parenting. But anyway, my point is that most kids are being raised in the permissive and indulgent management style, meaning that coachability is really not a priority. It's relationship, and it's not coachability. Authoritative parenting, which works the best for most kids, according to the 60 years of research on this, is about coachability. You want to be able to say, son or daughter, I need you to do it this way now. And then they thank you for that, ideally. And then they benefit from those words, and then they go forward and they want to impress their parents. The majority culture right now in terms of parenting is not about coachability, it seems. It's about relationship. It's not about coachability. Ideally, you want both. So my point being that those kids, when they get to college, tend to be lost. They've never done their laundry before. You know what I mean? And they used to have these parents who were quite doting and, and what can I do for you? And what do you need? But when they get to college, no one cares. You know what I mean? So they're kind of, oh my gosh, like this world is, really like uncaring. Good Lord. And I think that there's a kind of a intermediate step there between, let's say elementary and middle and college. And that would be the adolescent kids, especially the girls. You add to that what Jonathan Haidt has been talking about recently, which is the effect of social media. And in fact, well before Haidt was talking about this, we were learning about this, about 10 years ago, where, there seems to be something up here in terms of the effect of social media, especially with preteen and teen girls, for whatever reason. I don't know what the reason is, but what the mechanism is there, but it predicts some things. A lot of social media use predicts certain outcomes right now. So, it's a combination of factors. When you help families, when you're in a position to help families move toward more of an authoritative parenting and management style, then there's a whole lot more healthy attachment bonding there between parents, which, by the way, parents I meet they crave that, but they don't know how to get it. It's almost like permissive and indulgent parenting kind of gets them somewhere, but not to the finish line. But if they don't do that, and they become more kind of authoritative from their point of view, from the parent's point of view, then it kind of hurts their relationship on the short term. Authoritative parenting is the solution for a lot of that for most parents. And that's one of the key features of my approach in session with parents, is to help them know to be firm at the same time. And there might be a momentary, kind of short-term dip in relationship, but you're building a solid foundation for the future. And I think that that's a buffer. Thinking about like Camille's work, I would say that that's a buffer for the preteen and teen years, that there's more of a relationship there. There's more communication and not isolation among teens right there. They're kind of off on their own. And they've got this curated feed in their social media, that's giving them maybe messages that are less than healthy for them at that moment. So, this is a longer conversation.
Yeah. I'll just throw one more thing out there in terms of, I've got friends who tend to be more on the permissive, indulgent side of parenting. And oftentimes if we're, if the families are hanging out, we're at like a barbecue or something like that, like my wife and I will take turns breathing into a paper bag, witnessing some of these parent-child interactions, particularly if we have friends who have much younger kids than we do. And it's like, you don't have to live like this, but that's, in addition to, I suppose, the worry about, getting called by child services, I sometimes see this more on a molecular level, like in terms of like, it's, the smaller, sooner reward is to give the kid the iPad or to let them stay up a little bit later or whatever, because setting that limit is going to, as you say, engender a temporary dip in relationship. In other words, there's going to be some displeasure, amongst the child, some gnashing of teeth or whatever you want to call it. And you can forestall that by capitulating, essentially. Whereas the larger later reward is to, kind of slog through some of that momentary unhappiness, right, knowing that you're building a more durable more healthy repertoire in the long run. So sometimes I think of you're making a marshmallow test.
That's exactly right. I was thinking, it just occurred to me. Sorry to interrupt you too.
No, go ahead.
It just occurred to me that parent training, getting parents to move more toward authoritative parenting, is basically pointing out there's a second marshmallow there.
Yes, indeed. All right, so we go down 1,000 rabbit holes here. I'll try to wrap this up here. So, Chris, this is always fun chatting with you. I'll let you have the last word with some parting thoughts, I suppose, whatever you might want to leave the audience with. But I want to make sure that people know where they can learn more about you, the Institute, the book, et cetera. And if you had any kind of parting advice for BCBAs, this is the time to give it.
Gotcha. Okay. Well, thanks for having me, man. This was fun. It's an honor to be on your podcast, and thanks for the invite. I really appreciate it. So let's see, I guess I could say my website, as far as my practice, is McGinnisBehavioral.com. And that can serve as an exemplar to folks who are thinking about going into ultimately or eventually private practice. And you can kind of see how I set up the website. And then there's also the CE platform that I've started recently, and that's the Institute for Behavioral Pediatrics. I've got big plans for this, but we got to start somewhere. And that website is and then the number 4 bp.com. You can also type in Institute for Behavioral Pediatrics. That works too. But i4bp.com. Right now there are 3 CE offerings. If you buy the book and then you want to get 10 CEs for that by taking a 50 question quiz, that's one of the offerings there. So that'd be a nice bunch of CEs there that you can get all at one time. There's also one on ethics for behavioral pediatrics. And there's also a 1 CE kind of overview of everything we just talked about there. So that's on.
Great. And I'll have links to those in the show notes, folks. So if you're driving, don't worry. Just go to behavioralobservations.com, look for this episode, or sign up for the email list. You'll get the show notes delivered right to your email inbox. All right, go ahead. Sorry.
Thanks. Yeah, no, that's okay. Thanks for sharing that. I want people to know about the CE platform because, again, that's part of what I'm trying to do here to facilitate this.
Mm-hmm.
And, gosh, there's a way to contact me through that too. So if anybody has any questions about anything, you can shoot me an email and I'll try to get back to you as quickly as possible. Anything that you think I could add to the platform as far as topics, whatever I can do, please let me know and I'll consider it because I'm here to serve folks out there who can help me build this subspecialty. That's my mission right now. And then as far as, kind of general advice, I'll say what I say to, my teen clients here. There are people in your life that you should really trust. And you should lean on and you should ask questions if you have them, when you have them. And, lean on the people in the field, for example, who came before you. I could have done a better job at that all along. You know what I mean? The older you get, the clearer you see things in retrospect.
Oh, of course. Yeah.
And so I would want, just the fact that, you've been doing this for so many years and you've got such a cache of wisdom from, so I'm not including myself in this, but I mean, just, people that you've interviewed all along. I mean, I've begun to go back and see who you've interviewed. It's just a wealth of knowledge that in a format that is not typical of the classroom or even a practicum situation or even a, supervisory session. It's you get so much more. It's just really rich. And so thanks for doing this, Matt. You're just, you represent one area of resources out there that behavior analysts, young behavior analysts especially, really need to tap into and just kind of be part of our community this way and learn from those who came before.
All right. Dr. Chris McGinnis, thanks so much for joining me. It's been a fun conversation. We'll have to do this again sometime down the road.
I want to. And thank you for having me, Matt.
Hey, if you're still here, I just wanted to thank you for listening to one of the longer episodes we've had in quite some time. I hope you really enjoyed it. Go check out Chris's website. I've got all the links in the show notes for this episode. That's at behavioralobservations.com. If, again, you enjoyed this episode as much as I did, I would really love it if you shared it with some friends and colleagues. And if you had a minute, go to your favorite podcasting platform and leave a rating and review. And feel free to shoot me an email if you have any comments or questions. You can go again to behavioralobservations.com and click the contact tab, and you can shoot me an email. So thanks again for checking out session 266. Thanks to Chris for joining me in this important episode, and we will see you in the next one. Take care.
Thank you for listening to the Behavioral Observations podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.